This is Thandeka Dlamini today on this day, July 19th at 3:48 p.m. Conducting an interview for the Global Oral History of PEPFAR in Eswatini. So to begin with, I'd like to thank you so much, Dr. Caspian, for your time to participate in our interview and this project. Please start off by introducing yourself, briefly telling us about yourself, your family, where you're from, where you were born, and your training, academic training.
Sure. Thanks, Thandeka, for this time. It's an honor to be part of this interview. I feel humbled just to share my journey, my story with you and everyone else. So my name is Caspian Chouraya, not an easy surname to pronounce. I was born 47 years ago on the 17th of February 1978 in a very small town in Zimbabwe called Rishavane. So it's about 400 kilometers, just about 400 kilometers south of the capital city of Harare. It's known as a mining town. We used to mine asbestos there. But I wasn't from the town itself. I stayed, I think, about 10 kilometers from the town in a rural area. So I'm a rural boy. I grew up in a very, very rural area. They used to call us Asarabis, strong rural backgrounds. So I grew up, of course, herding cattle, doing the farming in the morning before you leave for school. So I stayed in the rural areas, I think, almost all my childhood. I'm married for 20 years. Actually, I celebrated my 20th anniversary this year in April. I have 2 children. My son, Takuzwa, he is 17 years old, and he's doing his IB1. And my daughter, Tinotenda, she's 15 years old, and she's Form 3. So I'm married to Caroline Chouraya for 20 years, as I indicated. So yeah, I grew up in a rural area, did my primary school in a school called Ingome Primary School for 7 years, and I always tell people I was made a head boy when I was in my 7th grade. I then moved to a mission school for my high school. So I did my primary from 1984 to 1990. And then 1991, that's when I started Form 1 at a mission school. It was called Dadaya High School, again in Rishavane, just a few kilometers out of the mining town. So I did my Form 1 to Form 6 at that mission school. So I finished my Form 6 in 1996, and then I was made the head boy again in high school. I always like to highlight those those moments. I then moved for my tertiary education. I did it at the University of Zimbabwe from 1997 up to 2001. So it was 5 years. The degree I was reading was Bachelor of Medicine and Surgery. So I did that for 5 years as usual. We, of course, had some bit of strikes here and there that delayed us finishing. I think we ended up finishing slightly late, a couple of months later, I think in around 2002 or so. And then I did my internship or housemanship at Harare Central Hospital and also Parirenyatwa Hospital. And then I started working as a senior house officer, residence in internal medicine. I then left Zimbabwe in 2006 to join the Elizabeth Glaser Pediatric AIDS Foundation here in Eswatini. So I've been with PEPFAR in short since 2006 up to now. So actually I celebrated my 19th anniversary with PEPFAR this July. I'll pause there for now.
Oh, thank you so much for that elaborate intro, really understanding what you have done and where you come from and up to here. So let's talk about your career. How did your career start off? I know you were in medical school and training for so long. You're in Zimbabwe. How do you move from Zimbabwe to Eswatini, and how did you get into PEPFAR?
Yeah, so I think when we're just about to finish our training, actually, when our third year, fourth year, I think that's where we had the peak of HIV. I remember during those days, there's nothing you could do for patients that had HIV. All we could do was just watch them waste away, get sick, and then they pass on. So it was so difficult. I mean, looking at the conditions of clients and patients during those days. So there are a couple of reasons, honestly, that made me leave Zimbabwe. First of all, I wanted to just further my experience, my career, especially in the field of HIV. I had started working in the HIV arena when I was in Zimbabwe at Harare Central Hospital. We used to run what we called an OI, or opportunistic infections clinic, during those days, and that's where we would see clients living with HIV, initiate them on ART. I think back then that was in like 2004, 2005. The ARVs were not readily available, so actually we would have a booking system. Clients who you have to wait for about 6 months, or so before they got initiated on ART. So anyway, I moved because I wanted to just broaden my experience and my skills when it comes to, just the medical field, but specifically HIV as well. And the second reason, which is known maybe worldwide, is our country had also started just to go down economically, so it was a little bit difficult again to survive, if I can put it like that. You could still survive, but there are certain things that we're no longer able to do. So we also had to leave just because of some of those economic issues that we'd begun to face as a country. So when I applied for a job for PEPFAR, I was actually interviewed when I was in Zimbabwe, and then I got offered the position. I remember it was my first time actually to be in an aeroplane from Harare to South Africa, and then later on to Eswatini. I arrived late in the evening, and then I joined the Elizabeth Glaser Pediatric AIDS Foundation from 2006. I think over time I've also been able to study, a little bit more. I did a postgraduate diploma in HIV management from the College of Medicine in South Africa. I also did my Masters of Science in Epidemiology from the University of Pretoria. I've also done a postgraduate diploma in infectious diseases as well. So I think those are some of the courses that I have added over time. But my journey has been mostly with PEPFAR, starting from different positions to where I am right now. I'm sure we'll talk about those a little bit later. Yeah.
So, I mean, you're trained in medicine. Why specifically working on HIV than to focus on other disease areas, for instance? What was your reason for wanting to work in HIV?
Yeah, I think it was the time that we finished our medical school. I think that was the peak, honestly, of HIV. That was like the main issue, the main condition. So all the other diseases, I mean, were still there. People were still being treated for those, but the main challenge during those days was now HIV. Almost every other client, I used to work in the internal medicine department when I finished my internship, and honestly speaking, almost, I would say 80-90% of the clients that we're seeing had HIV and HIV-related illnesses, be it meningitis, be it pneumonia, be it TB. So that was like the main condition. I know things are getting better right now because of the treatment that has become available. Back then there was no treatment, so I think that also just skewed my interest towards HIV, so that we could assist as much as possible. And it actually was an emergency during those days. Like I indicated, the bulk of our clients, of our patients, were suffering actually from HIV, and there was no treatment. I would remember, doing ward rounds, and I mean, all you could do was provide palliative care, and that was all we could do. And ARVs were available maybe only for the rich. I remember the first time I saw an ARV, it was those days when they were still trying just not a combination, a treatment. It was just like one drug. It was Zidovudine. I remember one of our consultants brought a bottle, from a client who was private, and like, okay, this is how ARVs look like, and they'll just take it. But even then, because it was just one drug, unlike the combination treatment that people are taking right now, it wasn't really that effective. So people be okay, maybe just delay the inevitable for a short while. So honestly, the main reason I would say I was skewed because HIV and related conditions were like the main issue during that period. I think that's what really drove me to focus on this field.
Mm-hmm. So, I mean, during this time, how was the condition of, like the state of the African involvement or government? Like, what were they doing like at this time? Because we're trying to understand the build-up. What were the circumstances of the landscape of HIV treatment before PEPFAR came on board, which definitely made a difference? I mean, what would you say was the focus of different African governments, or the Zimbabwean government? As you were based in Zimbabwe, you came to Eswatini. Yeah, what was the focus?
Yeah, I think during those days, honestly, governments were struggling for a number of reasons. First of all, treatment was not available. I mean, they were doing their best. I will speak maybe during those days of two main governments that I worked closely with, the government of Zimbabwe and also the government of the Kingdom of Eswatini. I mean, the commitment honestly was there from the government of Zimbabwe, even from the government of the Kingdom of Eswatini. I remember His Majesty the King, he had actually to make declarations just to show that, there was political commitment to ensure that we could all, address the pandemic, during those days. So I would say at that time, they did their best in terms of just being politically available, making the necessary commitment. The challenge, of course, was treatment was not available. So even if you have the commitment, all you could do was encourage people back then to test and make sure if they're HIV positive, they live positively, eat healthy, like I say, delay the inevitable. So the messages were mostly just prevention, the ABCs, as we used to call them back then, and then test, So there was a lot of political commitment. We had leaders that will come up, speak publicly, encourage people, publicly to do their level best. But the only challenge was, once a person was diagnosed with HIV, even if the governments wanted to do something, there was literally nothing that they could do. So it was a bit, a difficult period, if I can say that. I know several governments were trying their level best just to provide some of the basic needs that people living with HIV would need, but it wouldn't really go any far. So I think the main thing for me was the political commitment. Most of these governments really were able to commit politically when it comes to both prevention, encouraging people, to get tested for HIV. Financially, of course, it will vary from government to government, and we'll talk about that maybe later when PEPFAR came in, and maybe even right now on what exactly the governments were supposed to do. So yeah.
So, did you know about PEPFAR before coming to Swaziland?
Actually, no, I didn't. I didn't.
Tell me about, if you can recall, the first time you heard about PEPFAR.
I think when I heard about PEPFAR, it was when I came to Eswatini, so I'd say around 2006, 2007. When we started implementing some of our earlier projects as ECPAF. So when I came, I actually started as a medical officer with ECPAF. Maybe I'll talk about that a little bit later in a facility. So again, getting to understand about the programming of HIV, who PEPFAR is. Was not really like my all I was interested in was seeing the clients, and making sure that they are taken care of as needed. So when I started moving up, within the organization and my roles and responsibility changing, I would say around 2007, 2008, that's when, I started getting a bit of clarity on what exactly PEPFAR is, what they were actually doing. But back then, even when I was in Zimbabwe running, at the opportunistic infection clinics, I did not know much when it comes to PEPFAR. We just knew our government is trying their level best to provide, treatment for opportunistic infections and all those kind of things. So later on, I would say around 2007, I would say maybe that's when I started getting some clarity on PEPFAR and what exactly it is.
So it does seem like you started from a very ordinary level in the organization up to now you're working on the regional aspect. Take me through the journey. So I wasn't aware that you came in as a medical officer. I thought maybe you came as TD. So just take me through the journey. When you're a medical officer, you were based in a hospital, like a summary, high level of what you were doing, and up to now, how your role have expanded in the organization.
Sure, yeah. So like I indicated, I came to join the Elizabeth Glaser Pediatric AIDS Foundation in Eswatini, July of 2006. And my initial role was to work as a medical officer. So I was seconded not even to a hospital, not even to a health center. I was seconded to a clinic or a public health unit, which is called King Sobhuza II in Manzini, just opposite RFM hospital. So that's where I started to work. I think usually public health units do not have like a resident doctor. But the reason I was seconded, I was placed there was we were trying to I do something different when it comes to pregnant and lactating women. As the Elizabeth Glaser Pediatric AIDS Foundation, when we started, honestly, our focus was mostly on pregnant and lactating women, preventing mother-to-child transmission of HIV. That has been like our core mandate, our core mission, children and preventing HIV, to them. I think you might know how ECPAF started, the story of Elizabeth Glaser,
well, get into it, because it's a question after, so you can just talk about it
Sure, yeah. So I'll come back to my journey as well, but let me start with just the story for Elizabeth Glaser so that it feeds into exactly what we're doing when we started and how we grew up over time as well. So Elizabeth Glaser was a famous American woman, married to Michael Glaser, who was actually a movie star, a TV drama that he was acting called Hatch and Starsky or something like that, so long ago. So unfortunately, Elizabeth got transfused with HIV positive blood. It was back, in the 80s where screening even for blood was not being done that much. So she bled when she was delivering, and then she was transfused with HIV positive blood. And then she only realized that way later after she had given birth to a first child, and then she unknowingly transmitted HIV, to a child called Ariel Glazer. Unfortunately, Ariel passed on. So if you look at the logo of PEPFAR, you'll see this flower, this painting that was actually done by Ariel before she passed away. And again, back then, even in the US, there was nothing you could do. Once you have HIV, that was just it. So Ariel passed away, Elizabeth, passed away. But before she passed away, she and 3 of her friends, just started this organization. And primarily it was to just do a lot of research, a lot of advocacy to make sure that, children do not get HIV. And honestly, she did a lot. She did a lot of advocacy, went from door to door. And our work, actually, the work that she was funding when the organization started was mostly around research, especially on pediatrics. What can be done to make sure that, children don't get the HIV, and if they get the HIV, again, they're able to get the help. Because back then the focus was on adults, so children always get left behind. And I'll come to this even a little bit later as well when we talk about the successes and what's lagging behind, because even up to now, I should just say right now, children are still lagging behind. Despite all the successes that we are celebrating, children are still lagging behind. We still have a lot of children. Out of about 1.4 million that are living with HIV, only about 55% of them are on treatment, compared to adults. So this is some of the work that Elizabeth started, just doing the advocacy. And as an organization, our focus then became on pediatrics. And we worked quite a lot. And even right now, we are known for, programs around prevention of HIV transmission, from the mother to the child, now known as vertical transmission. Coming back to my career with ECPAF. So when I came in, I indicated that I had to be seconded to a public health unit. So public health units in Eswatini are like maternal and child health clinics. So that's where the bulk of your pregnant women, under 5 children are being seen. So that's where you get the provision of maternal and child health services. Hence the reason I had to be seconded to a public health unit called King Sobosa II PHU. That's where, it was actually, if I'm not mistaken, either the second highest facility in Eswatini, where back then it was Swaziland, in terms of the number of pregnant women that would be seen for their first antenatal care. So it was a very high volume facility, and the idea was, we want you to go there to make sure that you could work, to assist pregnant women, especially those who are HIV positive, get treatment, get the care, that they needed. So when I started, it was a very humble and humbling beginning, humbling experience. It was a small facility, very few rooms. For your own information, I used to consult clients sitting on the same bench. So we did not have even like a nice office or a consulting room for a doctor. So I would sit on the bench and the client will be on the same bench with me, and I'll be managing them, taking their history and talking to them, at there. So, but it was exciting, because the impact that would then provide there was just quite good. So I went there specifically to assist in bringing HIV services for pregnant and lactating women and also children. So I started as a medical officer from 2006. until 2008. And I think, like I said, during that period, it was mainly just to, assist the pregnant women, provide direct care, even for children under fives and all those kind of things. And I mean, over time, we also started with PEPFAR funding, started assisting renovations within the facility. Space became available, for us to do even much better. And my main mandate there was to actually integrate antiretroviral treatment into the MNCH setting. So that's one of the things I would say in Eswatini. As Caspian, as an individual, as ECPAF, we pioneered the integration of antiretroviral treatment within MNCH units, because what used to happen is if you're HIV positive and you are pregnant and you need to be put on treatment, you actually need to be referred to a main hospital, a main facility for you to be initiated. So my mandate of going, especially at this high volume facility when it comes to antenatal care, was to prevent that from happening. Can we just ensure that if a woman is HIV positive, they can be put on treatment, at that particular facility? So that's the first thing I started doing, and we successfully did it, published and made a lot of papers as well, shared a lot of lessons learned in several conferences, just to share our story on how that worked. So that was my first work as a medical officer. I then got promoted to like a technical officer. So now the idea was this model of integrating ART within MSH settings is helpful. Even the uptake of treatment was improving. I remember I did even a paper, my first publication was also just around a treatment uptake for, these pregnant and lactating women. So the idea now was, can you work, with other PHUs? So public health units used to be attached to a main hospital. So your main hospital, like Mbabane Government Hospital, Mankayane Government Hospital, does not provide MCH services, maternal and child death. They are provided at the public health units, and these are separate, facilities. So now it was to try and work with those PHUs or public health units in all the, facilities in the entire country to make sure they do the same. It was not an easy job, but again, with the commitment, especially from the ministry, I vividly remember I used to work back then with the then ART coordinator from the ministry, Dr. Velepi Okello, who is now the director, of health in the ministry. And we used to drive together, visit the public health units. And as ECPAF, we had this small red Kia Sportage. I don't forget it. And I'll be driving here, and we go to the facilities, Mankayane, all over, the 4 regions of Eswatini, Peak, just trying to encourage, set up, this integration. And we managed to do it successfully in all, the public health units. So women were no longer being referred, to another place for them to start ART. So we took it from just case 2, and then we scaled it up, of course, working closely with the ministry to other, public health units as well. And it was successful. Of course, there are facilities that were difficult, from the beginning. I remember one of our very difficult facility was Mbabane Public Health Unit. I think that was the last one to actually integrate. We went together with Dr. Okello, and when we came back from that meeting, I remember Dr. Okello telling me, what, let's just forget about this facility. Let's do all the other one and forget about. But we did not give up, honestly. We continued working with the healthcare workers there, the nurses, and finally we managed to do it, and all the public health units were now able to initiate ART. So that was a technical officer. I then got promoted to a technical advisor, and then I got again to become a technical director. I was a technical director for ECPAF, I think, for almost, I think that was my longest, if I'm not mistaken, from 2010, I think, to around 2018 or something like that. So almost like 8 years. I think that was one of the position that I stayed in for a long period of time. And my role then he had changed. So I was now playing a more strategic role when it comes to the technical direction of the organization, a strategic role, making sure that I provide more inputs, even working with the government through the technical working groups on development of guidelines. My areas of focus when it comes even to the guidelines were pediatrics, and PMTCT. Back then we used to have separate guidelines, a guideline for PMTCT, a guideline for testing, a guideline for pediatric HIV, so they used to be separate, and our focus was on PMTCT and also pediatrics as well. So I was a technical director for about 8 years until 2018. And then I moved into a role as a country director. I always tell people that was not one of my favorite positions. I was always telling people I don't want to be a country director. I want to remain as a technical person. I love my technical work, but there were a number of things that happened back then, and I was left with no option. We had some funding challenges, funding cut, and our then country director had to leave. We couldn't replace him, so I had to step in, and then one thing led to another. I found myself later on being confirmed as the country director. I didn't stay for very long in that position, but this was more like now more strategic and also bigger, more not only just technical. I was also overseeing the operations, of the organization entirely in country. But even then, as a country director, I liked my technical work, so I'll always make it a point that I go to the facilities. I always reserved Tuesdays, to go out to the facilities alone, maybe with one of the mentors, and see how the work was moving, and provide feedback even to the team. So I've always liked the technical work. But I was a country director from 2018, I think, to 2024 last year, so didn't stay very long in that position, and then I got promoted to my current role. So currently I'm a regional director, and I oversee a number of countries for the Elizabeth Glaser Pediatric AIDS Foundation. I oversee Eswatini, I oversee Malawi, I oversee Zimbabwe, I oversee Tanzania, I also oversee Nigeria currently. So those are the countries that I manage directly. The country managers or country directors or country representatives in those countries report directly to me again. So again, it's a strategic role that also works very closely with the teams there to ensure that they are performing, the way they are supposed to be doing across all areas, technically, operationally, observing even our policies as a foundation and also our donor expectations. So that's my career journey, and that's where I am right now. Thank you.
Thank you. I'd like for you to explain to me, how was PEPFAR involved in the day-to-day running of these different programs? So if you have a particular program, how does PEPFAR get involved in that kind of a program?
Yeah, I would say most of the programs that we were implementing, especially in Eswatini, and even right now as I have a regional role, I can safely say 80-85% or upwards of the programs that we do, and even the funding that we oversee as a foundation, is actually from PEPFAR. It might be coming through the different agencies, CDC and USAID back then, before the current termination, or Department of Defense in other countries. So the bulk of the work that we do here has always been PEPFAR funding. Of course, we do get also some funding from other donors which are non-PEPFAR, but that constitutes, like I said, probably about 15% or even less of the work that we are currently doing. So the bulk of the work that we do as ECPAF, that we have done even here in Eswatini, it's predominantly, if I can say, a PEPFAR. So they funded us. They've also helped us. PEPFAR has helped even ECPAF to grow its programs, and even some of the funding we end up getting from other donors is because of the PEPFAR funding. So if PEPFAR is not there, it's difficult for you, because PEPFAR becomes like the base for you to get even funding from from Johnson and Johnson, from Elma, from all the other Gates and all the other foundations or donors as well. So I would say PEPFAR has been involved mostly in funding our programs as ECPAF in all the countries where we work in, and specifically here in Eswatini, where most of my career has been I've been there. So beyond funding, PEPFAR has also been providing guidance in terms of, the programmatically how we should be utilizing, the funding. I think every year they'll come up with this country operational plans, known as COPs, that will be very, comprehensive and provide clear guidance. This is how we should be doing our testing, this is how we should be doing treatment. So there was also guidance. Of course, this guidance would mirror what other bodies like WHO, UNICEF and so forth will also provide as guidelines. So there was also that technical guidance that will come from PEPFAR. Thirdly, so first, like I said, it was the funding. Secondly is the technical guidance. Thirdly is the oversight, just making sure that things are being done as they're expected, to be done. And that's one of the roles that I think PEPFAR played very well, especially during Ambassador Beck's time. I know there are lots of stories, controversies, and all those kind of things, but I think accountability became a huge area during that period, where now we are expected to make sure that things are being implemented as expected. Are you meeting certain targets? Are you getting where you are supposed to go? Are you reaching the right places with the service? So that oversight, ensuring accountability of every PEPFAR dollar that is put in there, was actually something that I would say was valuable. So PEPFAR was also involved in just ensuring accountability, when it comes to most of the activities that were being implemented. And the actual implementation, of course, it was through the implementing partner, but most of the scale up that we see of services, be it testing, be it prevention, be it, all these other services, PEPFAR, he has really been able to provide that support in the actual implementation. So I would say that's how broadly PEPFAR has been involved from my perspective.
I am also interested during your tenure as a medical officer and maybe technical officer as well, because you were more hands-on and more in the front line of service delivery.
Yeah.
So obviously coming in as an expert for medical interventions, you find there is already people that are working there, and there's a culture in which you have to fit into. I'm just interested to know, because we want to also know not only the technical, but how were you able to maneuver and to get into that space and begin to be functional, because you are in a different environment where you have never been before.
Yeah.
You want to also learn how does one get into such an environment and become effective? What would you say was a game changer for you to be able to? You're talking about working closely with Dr. Velepi.
Yeah.
Those partnerships, connections, and relationships are important. So if you could say something about that.
Yeah. So a couple of factors I would highlight for me that especially led to the successes that we talk about these days, especially in the early periods when I was a medical officer seconded to a very small facility. Of course, humility, to be frank with you, is key. If you get to a place and you are working mostly with nurses, you are a doctor, if you come in there with a I know it all attitude, I'm the doctor, I order you around and you have to do what I say, you're definitely going to struggle, to fit into that kind of and environment. So I think I had to be humble, and like I'm saying, wherever I be put in, even without an office or working closely with the clients, I didn't mind. I think it's something that was a humbling experience for me as an individual, and also, I mean, just based on my faith as well. I didn't find it as an area that I would say I struggled in, just based on what I believe and my faith. So I think humility played a big role. Just getting in there, knowing we are into this together. You are not know-it-all. You are not the doctor who can command. And I learned a lot, even from the healthcare workers there, from the nurses there. So the more you are humble, the more people are able to work together with you, assist you and take you around how things can be done. And I learned even quite a lot, from them. And also just the good reception, honestly, I received at this facility. King Sobuza Public Health Unit was amazing. The sister in charge was called Sister Dorcas Numalo. I'll mention here by name. She was an amazing woman. Like my mother, if I can put it like that. She would treat me honestly like your son. A very, very wonderful woman, and I was very well accepted, within the facility, and even all the other nurses, healthcare workers that were there. I think it became very, very easy just to move in. So I would say humility, not thinking yourself too much of anything, and just this acceptance, within this team. But my faith as well also managed to, help me, guide me, and lead me through some of those areas. I can't say I struggled at all at the PHU. I used to actually travel. I stayed in Babane, and I would travel every day to Manzini. I would use public transport. I will drop off at Gakoza, the bus station, and I'll walk to the clinic from there. I mean, to me, that was normal. Like I told you, I'm a rural boy. I grew up in a rural area, so that's not even a big deal, for me. So I would walk. And at one time, Sister Dorcas comes to me and like, are you walking every day? You are telling me you walk from Gakoza to here. And I'm like, yeah, this is like less than a kilometer. Why is it such a big issue? And like, do you know how dangerous that place is? Gakoza is the very dangerous place, in Manzi. I'm like, I've been doing this for months. I've never even heard anything. So I insisted, let me walk. And she said, no. So she would send a driver, imagine, from Gakoza to come and pick me every morning, to the house. So it was so humbling, to be frank with you, for me. But I think the acceptance and just the way I was received at the facility was quite overwhelming. I really am grateful, for that. And I learned a lot from every individual, even the driver. And I mean, everyone was just amazing. So, yeah.
Okay, so clinic, you're able to break through and you're gelling into that environment. So now your role being a country director, you have to liaise and interact with the larger scope of people,
Correct.
Different cadres, that is, and higher levels of civil servants, people that are in government, reputable people. So how were you able to also like get into that space, if you may explain to us?
Yeah. So even when I became a country director, I never lost my way of doing things. I honestly respect people for what they are. As a country director, I would say this even to a number of people. Some of the successes, or most of the successes that I actually was able to have at that level was because of working closely with some of the junior staff. So first of all, I did not lose touch with the entire team. I would sit down with drivers. Just even as a country director, I made it a habit. Just come, let's see it. What are you guys saying? And you'll be surprised the amount of information that you get from drivers. So I continued touching base with the staff. at whatever level they are. So I'll do this quite frequently. Just meet with the teams. You might be a cleaner, you might be a driver, you might be a director, whatever you are. To me, you are part of the team, and you are just assisting, to make sure that we achieve the vision. So I learned a lot, even from some of the junior staff as women. You'll be surprised the amount of wisdom that you get from so-called, junior staff. So that's one of the things I'll never lost touch with. I'll always, now and again, make sure that I sit down with those people. Of course, now as a country director, you can't do it daily. You have a senior management that you interact with, so I also didn't want to appear as if I'm micromanaging or overdoing what they're supposed to do. So like once or twice a year, I'll make sure I meet directly with each and every team, just to hear what are they saying, what are they seeing, what can we improve and all that. And I'm mentioning this before I talk about the high level, because for me, that's one of what I would say pillars of my success. It's not the interacting with the higher people, whatever. It's actually making sure that you interact with the grassroots people, with your staff at all levels, to benefit you. But yes, I've had also the opportunity to interact at all levels with people of authority, right up to His Majesty. I think I have a picture somewhere. Maybe I'll show you before we go. With him as well, he visited our offices in Babane. I've had an opportunity of meeting him one-on-one. Actually, he came into my office and I had to explain, the work that we do and all those kind of things. I've also interacted with the prime ministers, a couple of them, especially the late Ambrose Lamini, and also the current prime minister. I've been able to interact with the ministers as well. We've been able to interact and engage with them. And I would still say, again, humility when you go to those people is quite crucial. It's humbling, quite humbling, a humbling experience when you have to meet those directors, those big people, but just knowing who you are, remaining humble, not losing your touch, I think for me is what is important.
So I'm going to dive deep now into the type of programs that you are involved in.
Sure.
I know that you said one of the remarkable things that you are able to do as EPFAR was to bring the integration of services within a clinic, so that patients are not referred to the other facilities that are in the hierarchy.
Yeah.
So I know that there was male circumcision campaigns that you introduced. There was also an issue of women accessing art, because when women access art, then it will be a conduit for PMTCT, but there are cultural norms and issues there that needs to be navigated. So I want you to just talk about the cultural implications of introducing this kind of programs into enhancing PMTCT programs that you were doing.
Yeah, so just to start off with, ECPAF, we didn't introduce the circumcision program. I think it was mostly pioneered and introduced by your PSIs through the Soga Ngobe campaign. But yes, we did implement circumcision services as ECPAF. I think I would say we started doing that in one of our programs, which was called AIDS Free, again, USAID funded. We implemented that project from 2015, I think, to around 2020, 2021, or somewhere there. That's when we started doing circumcision. But I really would want to say we're not the pioneers or the ones that introduced it. The main area that we were focusing on right from the beginning has been pediatric HIV and prevention of mother-to-child transmission. And like you rightly said, there were several norms, cultural norms, that were really preventing women, from accessing the services, or even men from accessing the circumcision services. Let me start with women in the PMTCT arena, and then I'll come to men for the voluntary medical male circumcision. For women, one of the major challenges was just around male involvement. So we realized that women always needed permission for them to access certain services. if you test and your husband does not know, when you go back home and you tell him, that becomes an issue because you have to talk to your husband first and say, this is what I would want to do, and then he agrees, so again, that became a barrier because men would have to agree, to the woman even testing, and most importantly, taking, a treatment. So that was one of the major cultural barriers that we were faced with. Women always saying, I don't have partner support. I can't. Either they don't test, or they take treatment and default because their husband is not aware. And if they tell him, then that becomes an issue. Why did you do this without me knowing, and all those kind of things? So I would say, I think there are a number, but I would just want to highlight this main, we are in a patriarchal society, where men dominate, most African cultures are like that. And that was one of our major barriers, especially when it comes to PMTCT. We even did it a paper. I published a paper looking at the barriers to ART initiation for pregnant women. One of the factors that was a barrier, that was, as we'll always say, statistically significant, was partner support. The fact that I can't get my partner to support me was actually a significant barrier to women ending up not taking treatment. And what did we do? We had to move. We were more like a facility-based organization as ECPAF. We're working mostly in clinics and all those kind of things, but we had to shift. With PEPFAR funding, with USAID funding, we had to go to the communities. One of the largest things we started doing as ECPAF, I think it was in the 2010s or somewhere there, under one of our projects called EPAS, Eliminating Pediatric AIDS in Eswatini or in Swaziland back then, was to do community campaigns. So we went into the community and we did several and this is something that we had not thought about because we were just in the clinic. All we were waiting for is for people to come, give them their treatment and whatever. And then we realized there's barriers and we had to go. I remember our first community campaign was, I think it was a place called Mpuluzi, down there, and we had to work with the member of parliament then, and okay, we are facing a huge problem in the facility and we won't win this war if we continue sitting in the comfort of the facilities. We had to go into the community. So it started from there. We even had to add a team led by one of our program officers that we call the community linkages, team, a community mobilization team that did a fantastic job. So we ended up now doing a lot of campaigns. We used to call them dialogues, male dialogues. We'll sit down, with men, start talking to them, start engaging them. We did partnerships with drama groups like Smomondia. I remember that was one of our main ones, and we'll go, from one place to another. We train them, they talk to men, so we started going into the community just to try and address these issues of our community challenges. And at one point in time, we even got funding from the Canadian government, not PEPFAR supported then, just to do a proper community intervention. We had to actually do it in 3 countries, and it was even a research, randomized community kind of a trial in Uganda, Zimbabwe, and Eswatini, and it was looking at male engagement when it comes to improving uptake of PMTCT, uptake of maternal and child health services. And the intervention there were, community days where we'll sit down with men, talk to them, talk to communities, educate them, hear their issues, address them. And we also had community leaders training. So we actually recruited community leaders in each community, and we trained them, we capacitated them, to go and provide, some of these services as they move around in their meetings. They also talk about PMTCT and HIV. And the third intervention was classes that we introduced in the community. We call them MSH classes, where women will sit down, not in the facility, but in the community. And then we go and teach them, train them, on what they're supposed to do. So I would say from the PMTCT side, one of our major cultural challenges was the male involvement. And we had to actually move into community work just to try and mobilize men for that. Coming to the circumcision, I think the fact that circumcision is not a standard kind of practice in Eswatini made it difficult. I mean, even up to now, if there is a program that has really struggled, to get to the levels of all the other programs, is circumcision. And it's because this is not like a practice that is done, normally, unlike in other countries. So we honestly struggled, and even up to now, we continue just struggling when it comes to the uptake of circumcision. And there were several myths, around circumcision. Why are they doing it? Where they're taking the foreskin to? What then happens? I mean, several things that we had to deal with. But again, we've tried, to go into the community, do this dialogue, sit down with men, and make sure that we address some of these myths that are around, that are surrounding, a circumcision. There has been improvement. I don't want to lie when it comes to the uptake of a VMMC, voluntary medical male circumcision, but we are not to the level where we would rather be as a country. I think let me just stop there, focus on these two barriers or cultural norm barriers that we have faced. Yeah.
So we have learned that EPFAR played an instrumental role in other collaborative projects that were funded by PEPFAR, for instance, in Siga ya Kusasa. Can you explain to us how EPFAR got involved and what was the specific role that EPFAR was playing in this project?
Yeah. So in Siga ya Kusasa, which means the Pillars of Tomorrow, was a dreams program, for adolescent girls and young women. We got into a partnership. It was actually led in Eswatini by PACT. So we sat down. I mean, PACT has been like a lead when it comes to engagement of adolescent girls and young women when it came to OVC, services and provision of programs, around those population groups. So we decided to partner with them. They were the prime or the lead partner, if I can say. And we said, you know what, you are very good in this, working with adolescent girls, young women. Can we partner with you specifically to provide clinical services? So the main goal for the Insiga ya Kusasa, or Triple R program, project as we called it, was to actually reduce HIV incidence or new infections in adolescent girls and young women, and also reduce the levels of vulnerability, when it comes to these young women and also adolescent girls. It was actually a partnership of 3 organizations. It was PACT was leading it, and their role was to be, of course, the ones that were engaging, mobilizing the adolescent girls, young women, going into the community, talking to them. I think it was being implemented in about 24, 28 Tinkundla or constituencies. So they were the lead, actually mobilizing, talking to the girls, making sure, they are educated about what they were supposed to be receiving, how they can prevent HIV, how we can reduce, them from being vulnerable when it comes to acquiring, HIV. So PACT was the lead. The other partner that was there was Johns Hopkins University Center for Communication Collaboration. I think it was HC3 back then when we started the program, and their role really was around social behavior change, communication, how to talk to some of these girls, how to engage them, mobilize them to make sure that they do understand what they need to do to reduce, their risk of getting HIV. Our role as ECPAF was then to come in and provide the clinical services. So we had mobile vans that had a driver, we also called a logistic assistant. We had nurses, we had counselors, for testing. We had even some expert clients, in those teams. So this team would actually go to a community. PACT would do the mobilization, talk to the women, the adolescent girls and young women, engage them, educate them, and all those kind of things. So our role was actually to go. So we had these vehicles that we called Dreams on Wheels, vehicles that would then go drive right into the deep of the community. So this was not a facility program. This was a community program where the clinical services were actually being provided in the community. So that was our role as ECPAF, to provide the clinical services. It was an amazing partnership. PACT will do the mobilization. HC3 will do, the social behavior change, education, campaigns, and all those kind of things. And then we go in and provide the services. And we provided a wide range of services, from HIV testing, even initiation of treatment in the community for the adolescent girls and young women that will find to be HIV positive, preventative services, family planning services. We're providing sexual and reproductive health services. I mean, it was, and we started even integrating some of the, non-communicable disease management. So if you come in and you have hypertension, whatever, though it was not quite prevalent because this was a young population we're dealing with, but we would then, just manage you in the community. So that was our main role, providing clinical services in the community using mobile vehicles. So we'll go from one area to another after PACT had done the mobilization and provide the services. I would say it was one of the amazing activities that we were involved in. Unfortunately, we didn't, it was a 5-year program. We didn't get to the end of the program because then there was a move towards localization, of funds, from PEPFAR. So I think we're in our 3rd or 4th year, if I'm not mistaken, where we actually had to transition our role as a clinical service provider to a local, institution. So we didn't do the entire 5-year period of the program. I think we went up to 3rd, 4th year, and then we had to transition everything that we're doing to a local implementing partner because of the localization of services as well.
Can you please expand just that piece you just ended with about you not being able to finish 5 years because of the localization agenda? I mean, please elaborate on that.
Yeah. So I think, as you know, at one point in time, PEPFAR had these mandates, that were given to most of the agencies, CDC, USAID. We were USAID funded. Triple R, our Insiga Kusasa, was USAID funded. And there was this mandate where there was an expectation for about 70% of the funding for USAID to be given or led by local implementing partners. ECPAF is an international organization. So in the 3rd or 4th year, that became like a very a huge agenda, for PEPFAR, for USAID. Where are you with the 70%? So as part of trying to make sure that that process is fulfilled, we as ECPAF now had to relinquish, and transition the role that we were playing under Triple R to a local partner so that most of this funding could go to local implementing partners, which I think they did a very good job as well as a local implementing partner. So we had to move out and then transition. And I think this is something probably I might speak briefly on. It's been a journey, our journey as ECPAF. I always talk of 3 phases that we have gone through as ECPAF. We started our work here in Eswatini around 2004. To around 2015, I would say it was an emergency phase where the focus was really making sure that clients, women, are accessing service. So those first few years, from around 2004, when we came into the country, to around 2015 or so, we were just focused solely on PMTCT. That was our main program area, if I can say. PMTCT, making sure that these services are available everywhere, integrating the services as I indicated earlier on. So when we started during those years, we're working in all the 4 regions of the country. And one of the brilliant things that we're able to do, working with other partners, with the government, with UNICEF, was then to scale up PMTCT services from almost 3 facilities, I think in 2004, to 100% of public health facilities, even private facilities, being able to provide PMTCT service, whether a small clinic, whatever, in all the 4 regions. I think that's one of the things that we're really proud of. I remember we started with the call to action program or project that we're doing back in the 2004, went up to around 2010. From 2010, we got an award, the EPAS, or Eliminating Pediatric AIDS in Swaziland, and our focus even during that period was solely PMTCT. So it was like an emergency phase where all you wanted to do is let's make sure, the services are available everywhere, in every place. And we're focusing just on that area. None for PMTCT, none for pediatric HIV. So that was the first phase. And then came the second phase of us as EPFAR. This is specifically as EPFAR. I know it might vary from other partners. This was a phase from around 2015 to 2022. PMTCT had become a huge success in Eswatini. We were one of the countries that did exceptionally well. Despite the high level of prevalence, of HIV among pregnant and lactating women, we're able to see huge reductions when it came to, our vertical transmission rates, mother-to-child transmission rates, from around almost 18% in when we started in around 2004. So that means when we started, almost 1 in every 5 HIV positive women will transmit HIV, to their unborn children or to their born children. So that was a big issue. So we did very well. Even right up to 2015, those rates had gone up to down to less than 5%. So the emergency, I can say, was then averted, in that phase. So we did very well in terms of scaling up the services. I would say that was also done very well because, like I said, almost every public, 100% actually, not almost 100% of public health facilities were able to provide PMTCT services, as needed. So that was the first phase, emergency, from 2004 to around 2015. And then from 2015 to around 2021, 2022, we entered a new phase. So instead of focusing on one disease, which was PMTCT, sort of on one population, which were pregnant and lactating women and children, we then decided to expand. And this was, of course, working with our donor, working with our government, working with PEPFAR. They're like, okay, most of the emergencies that we have have now been stabilized. So again, instead of having partners, focus, be verticalized. So you go to one facility, EPFAR will be dealing with the pregnant woman, ICAP will be dealing with an adult, this one will be dealing on TB, and this sometimes even on the same person. So I'll come as EPAF, and I'll just deal with your pregnancy, and then ICAP will come to the same person and deal with your chest. URC will come and deal with your TB. So it was not very efficient. Of course, it was something that needed to be done in the earlier years because this was an emergency. So you needed people to focus on special areas. So during that period, we entered into a different phase as EPAF, where we expanded our scope. Instead of just focusing on pregnant women, instead of just focusing on PMTCT and pediatric HIV, we then provided comprehensive services. We did the whole spectrum of services for all individuals. So we broadened our clientele. We also broadened the work that we were doing as well. So in regards to that, we then moved, instead of being in all the 4 regions that we're in, we had to move to 2 of the 4 regions, Hoho and Shiselweni. And in those regions, we were providing comprehensive services. So we'll do the testing, we'll do the HIV prevention, we'll do the circumcision, like I indicated, we'll do every thing. So I would say this phase was the first phase was an emergency, just increasing our geographic scope, and then the second phase was more of us growing programmatically, increasing our programmatic scope and also clientele, focusing on everyone. So that went up to around 2022. And then from 2022 up to now, we entered into another phase. Eswatini had done very well and has done very well when it comes to HIV. We've done our different fears, and we've seen that the progress, even with the 95, 95, 95, is amazing, in Eswatini. So the emergency has been averted. Service uptake has really improved. People living with HIV are virally suppressed, so we moved into a phase as ECPAF of transitioning. So now we are trying to make sure that we start pulling out of some of the activities that we were doing and letting the government take as much leadership, and ownership of most of the services as possible. So from 2022, we started not scaling down, but transitioning some of our work, that we're doing. We used to hire, hundreds and hundreds of cadres in the facilities. We moved out of that. We transitioned those to nature. They became the custodian of those services. So we used to also do a lot of work procuring this, and so we started reducing some of those things and heading them over, to the government. So that's the phase that we're in from 2022. Unfortunately, in 2025, as you know, there were lots of things that happened with the foreign assistance review from the current US administration. USAID was terminated. Most of the work that we've done in Eswatini as ECPAF has been USAID funded. So we were affected as well when USAID was terminated. So in 2025, I think our programs and most of the projects that we're implementing, were terminated together with USAID. We still continue to work in Eswatini as ECPAF, now probably funded by private donors, if I can say, like VIV or J&J, but we continue to work very closely with ECPAF. So this has been our journey from emergency safe setting phase where we're scaling up geographically to a second phase where we're scaling up programmatically and clientele-wise to this actual phase, which I call phase 3, where we are now trying to transition and our role becoming maybe a technical advisor to the government, to the ministry, and providing support as and when needed. That has been like our broad journey, if I can put it like that, as ECPAF in Eswatini.
So one follow-up question. You mentioned that you had to transition out of the work you were doing because of the localization agenda, and you handed over that type of work to a local partner. Who was that local partner?
So under the RRR, the Insiga Yokusasa, it was a faith-based organization called the Look Commission, or TLC. So they are also a clinical a service provider. They run a miracle campus in Manzini in Stogoto. So they are the ones who then took over the Dreams on Wheels, the clinical work that we are doing as a local, organization, faith-based organization as well, to do the work that we're doing. But currently, when we're transitioning our staff that we had hired in the facility, we had hundreds and hundreds of expert clients, HTS counselors, data clerks, even nurses as well. We're hiring those. So we transitioned those to nature. The National Emergent Response Council on HIV and AIDS. So all those stuff, initially we were giving them the money to manage them as a sub-grant, but then they matured, and then now they were getting the funding directly, from PEPFAR, and they were managing those people. So we'd offloaded, or transitioned, if I can say, those stuff, to them. So our role changed significantly from the 2022s, even up to now. It was more of providing technical assistance, to the government at all the levels, at regional, at national level, even at facility level. We're no longer, if I can say, right in the forefront as we used to be. We were right in the forefront, doing the work, doing everything. But now we are beginning to move behind and let government do most of that, and we are supporting and continuing to work with the government, providing technical assistance as and when needed.
I'd like you to share some light. I mean, for that kind of a shift to happen, was it negotiated? Was it something that you were told needs to happen? What were the circumstances that led to that particular position happening and the effectual execution of that kind of a decision?
Yeah, I think maybe just a couple, and I think these are my thoughts as well. So like I said, Eswatini had done and has done very well when it comes to HIV, management, both reducing the incidence, ensuring that, uptake of services, testing, treatment, viral load suppression is being done. So the role now of most organizations yet to naturally shift, because also we don't want to continue like being the forefront, of most of these services. Yes, when the situation was an emergency, you need all hands on deck. But it's no longer an emergency. Things are going in the right direction. For sustainability purposes, you'd want government to start, taking more and more of what was being done by PEPFAR, by international organization as much as possible so that these things can be sustained. So the main driver has been to ensure that we sustain the work that we've done, driven by the successes that we wouldn't have done this if we're still struggling with testing, maybe only 20% of the people on treatment and people are not suppressed. I don't think we have done that, but the success is there. We've over 95% of the positives know their status, over 95% are on treatment, over 95% are suppressed. So it's no longer a big emergency. We want this to be sustained, and we all know PEPFAR, international NGOs are not going to be there, forever. At one point in time, the disease needs to be sustained, by the host government. So I would say this is what has driven it. Hence, the three phases that I mentioned, where we started in terms of emergency, scaling up certain programs and clientele, and now where we are moving on to a transition. So I think it's a natural kind of flow that would expect, to happen, especially in some of these pandemics.
What would you say has been the government's response to that transitioning? Has it been easy? Has it been smooth? Are there challenges? Where are they at right now with that kind of a process for them to take up leadership and implementation of what you at PEPFAR had started for all these years? And
Yeah. No, honestly, it's not an easy a process, and I would say it's a journey. It's not going to be an event. How long it's going to take, I think time is going to tell. So we are still in that process. It hasn't been, finalized. I know government has been committed as well, to be involved in this, and it's a discussion that you have to do with government, with the donor, do some assessments, see what they're capable of, what they're still not capable of, and then you work together, when it comes to that. I know other entities as well, like UNAs, you have come in just to help work even with PEPFAR, implementing partners and government to develop a clear roadmap when it comes to transition and also sustainability. And that's work in progress. And I would say currently that's like the focus, one of the focus areas of the government, of implementing partners, or PEPFAR. How do we ensure that these activities are sustained? Some of the challenges, honestly, as someone would say, is when we were implementing PEPFAR, we implemented more of a, maybe let me use a Mercedes-Benz or Rolls-Royce kind of a program. And yet most governments, not only in Eswatini, but in Africa, might not afford to absorb that kind of a model. And this is one area that we have had challenges in. PEPFAR came in, we hired all these thousands of, cadres that were needed, but most of them, government will not be able to absorb them because they might not have them even in the establishment registers, and they might not even have the funds for them to do that. Were these people needed? Yes, if you ask me, because it was an emergency and they played a pivotal role. They helped. But now that things have stabilized, will government be able to absorb all of them? To be frank with you, no. Most governments, and now in my role as a regional director as well, I'm able to see it's not a unique issue, in just Eswatini, but most African governments struggle to then absorb most of these cadres, and some of the way that we're doing things. Sometimes we'll build very nice facilities, put air conditioners, buy nice chairs and all those kind of things, but will government be able to do that. Some governments might be able to a certain level, some might not be able to. So the challenge, I say the greatest challenge that we are facing is how do we transition the model that we had built, to government based on where they are. The process is ongoing. Like I'm saying, there are certain things that government is saying, yes, we can. There are certain things that we are saying, no, we can't. Or there are certain, areas where we can say, okay, this is no longer needed. We can just try and work with what we have. So there's a lot of integration of services. One critical question is, do we still need to have standalone ART centers run by a different cadre, or now we can integrate it into, the OPD? You come in just like someone with high blood pressure, with diabetes, maybe you go to the OPD, and then you are just seen as someone with HIV by the same nurse. They provide you a treatment, and off you go. So those are some of the models that people are now beginning to look at. Integration. How do we integrate the services so that things become sustained? Again, if you ask me, did we need to build that model right? Yes, it was necessary because it was an emergency. Usually when we start with this emergency, things are verticalized because you really want to make sure you focus and hammer on that pandemic. But as things stabilize, we are moving now to this area where things have to be integrated. So I think that's where we are right now. What goes to government? What can government take? What models can we do to ensure that the gains again are not reversed? So this is the area where we are in. It's a work in progress. Like I said, it's a journey for different countries, and I hope that we will definitely get. But I will say this is the phase where we are in. Again, not all countries are there. There are still countries that are still struggling, even with the 95, 95, 95. So to them, it's still an emergency. There's still, so all hands need to be on deck. But a country like Eswatini, things have progressed, in the right direction.
Mm-hmm. So I want to find out now, to what extent, because I know that there were some cultural issues and norms that you had to consider as part of your programming to make it effective. So would you say that ECPAF was considering some indigenous knowledge systems in the way that you were doing your program? If you saw how, you can just give me some kind of examples.
Yeah, definitely. And I think earlier on I talked about some of these male challenges that we had in terms of uptake of PMTCT services and all those kind of things. And our approach was to look at the cultural, indigenous way that things are done in Eswatini and say, how can we fit in there? I'll tell you one of the things that we did, and maybe not too many people know this, we even partnered at one point in time with Lutsango Lwakangwane. They even have, there is an organization, just for traditional women and all that. We partnered with them. We even had a sub-grant where we're actually able to, work very closely with them, because we're trying to say, the culture. You know how to reach these women. You know where to go. You know how to do this. So we partnered with them and worked very well. I think it's the custodian is the Queen Mother and all that. And we worked with several people, and we'll go with them to most of these events. We will go and partner with them. Bugano, we have been there. The reed dance, we have been there, so we tried to fit into the cultural system. Instead of changing it, we partnered with people, like you are asking, indigenous people that know, if you need to talk to a woman or if you need to talk to these people, this is how you do it. So we worked very closely with those. We worked with traditional leaders in several, constituencies, like I indicated earlier on. We even did trainings with them. We even partnered with them to help us. So we're helping each other. They know how to reach. They know where to reach. All we're doing was giving them the information, training them, and then we go together. So we've partnered, honestly, with a number of indigenous organizations that have helped us just to fully and better understand, how we are supposed to address some of these cultural norms, cultural barriers, that I've indicated. I think the Lutsango Lwakangwane is one of the example that I can give. I think we even worked with Emakosikati. remember we even had at one point in time to do Emma here, that had messages for PMTCT that will be utilized by Emma Nkosigati. So again, these are people that are, you know, looked up to in our society. So we had to look for indigenous, you know, solutions just to try and address and reach, you know, most of these people as well. So yeah.
I want to follow up on the issue of, it's just coming up in my mind. When you were transitioning most of the work to the Look Commission, did you continue to collaborate, connect with them, like helping them on board in terms of what you were doing, up to the point whereby, you know, the resources were cut off, or it was just handing over, they do things the way they want?
Yeah, I mean, the Look Commission was already well established. They ran one of the from my own view, one of the best, if I can say, medical centers in Eswatini. I think they even did quite a lot during the COVID period, and so they really ran. And I've been to their campus. It's modern, it has high tech, you know, so they were already well established, even as a clinical partner. So even when we handed over to them, there was no need for hand holding, you know, we teach you this and whatever, because this is something that even themselves were already doing, you know. They were doing outreaches and, you know, providing services even in other communities. However, there are other local organizations that we continued, you know, to work with very closely. I'll give an example. Currently, in one of our awards, we had Bantwana, who was a local organization, and we brought them on board to do mobilization for circumcision. You know, worked very closely with them, and their local organization still growing. We had to work quite closely with them, do some hand holding, you know, go to them, do some audits, show them where they're getting things wrong, you know, and all those kind of things. The idea was for them now to lead, you know, some of these services. Unfortunately, like I said, our project was terminated before its end. It was supposed to end next year in 2026, so we had to terminate it. But the idea was by the end of 2026, Bantwana should be able to run this independently, and we'd already started working with them, hand holding, you know, because they were not like at a level, if I can say, that maybe they might receive direct funding from PEPFAR or where other organizations like the Look Commission were. So yes, we have done that. We've done hand holding of local implementing partners, and the idea is for them to be able to take over. But some of them, like the Look Commission, were already at a very good level. The Commission was even by then a prime recipient of PEPFAR funding as well. So they needed no hand-holding, if I can put it like that. But some other partners needed, and where we see a need, we definitely would hand-hold. So it will just depend on the local partner and the level where they are at.
What would you say was ECPAF's greatest transformation in Eswatini via PEPFAR funding?
Honestly, I'll put PMTCT as that was, if I can say, our core mandate when we started. Of course, I've gone through the phases and indicated how we evolved over time. But even up to now, I think you won't talk PMTCT in Eswatini without mentioning ECPAF. Of course, we didn't do it alone. We did it with other, you know, with the government and PEPFAR funding, as I indicated. But the greatest achievement, I would say, is PMTCT. In a number of areas, we're able to scale it up. Service provision, like I said, to 100% of the facilities. We've been able to scale up, you know, even the uptake of the services, treatment. Even if you go to your global reports, the recent report from UNAIDS that was launched, I think released recently, even shows some of the, you know, successes when it comes to PMTCT. So IRT uptake for pregnant women is quite high, you know, in Eswatini. But the greatest marker for me is the mother-to-child transmission of HIV. Like I said, when we started, it was 18%. And now we are beginning to talk of very, very low figures. 1.34% is what we are quoting at 18 months. And we know it's even less than that. This is like 2022 when we did a proper study, for that. But I'm convinced it's now even less than 1% mother-to-child transmission. I think for me, that's a great report. Even if you go to your UNAIDS reports and whatever, mother-to-child transmission of HIV in Eswatini is among the lowest, in countries. We haven't gotten, of course, to a point where we can say we've eliminated it. I think WHO now created this road to, or pathway to elimination, where they have a bronze, a silver, a gold, elimination path. The only challenge we can't get to that phase as Eswatini is because of our high HIV prevalence around around antenatal care attendees, ANC attendees. So we have a high HIV prevalence. Once the prevalence is high, it's so difficult for you to, reach that transmission elimination. But if you ask me, biggest success, I think is the work we did when it comes to prevention or elimination of mother-to-child transmission of HIV to the levels where it is right now. That, I would say, is a legacy we as ECPAF can live here in Eswatini.
And it's without argument that Eswatini did lead and provide an example in the region about PMTCT.
Correct, yeah.
Success. What would you say was the most contributing factor for that success? Because I see you were there right from the formation stages, early infancy, and you've seen this process through. You were part of it and frontline.
Correct.
So what would you say was the
a number of things that I will highlight for that? I think the first one, political commitment. Our government in Eswatini has been committed when it comes to implementing, adapting, most of this way. Just that commitment, you have the support. Like I'll tell you, you go to Dr. Okello, this is a high-level person, and you go together to one facility by facility, encouraging people, let's do this, let's integrate. So that commitment, political commitment, I would say was a big recipe. Right from His Majesty, declaring HIV a national disaster, rallying people. I think that political commitment played a very pivotal role. Number two, PEPFAR funding. PEPFAR funding played a key role. All the work that I talked about, all this integration that I talked about, all these services that we're providing, it was from the PEPFAR funding. So the PEPFAR funding also played a key role. Thirdly, it was the swiftness in adapting new guidelines and new interventions. Eswatini is one of the countries that has been very swift. When something comes up, it's working, it's doing well, Eswatini will not drag its feet. They'll move quickly. Again, it's tied to political commitment, but I think just swiftness. So we wouldn't delay. If a drug comes and they're saying this is the best drug, Eswatini will be in the forefront, taking it up, moving it forward, implementing it, as needed. We've done a lot of research even here. I know maybe we'll talk about research, I don't know, later on. But the number of researches that we've done in Eswatini, and one of the researches that we did was around the drugs, how effective the ARVs are, especially for children. And immediately we found that one of the drugs we're using, it was nevirapine back then, children that were on that drug were not suppressing the virus as better as children that were on other regimens. Immediately, the results came out and we saw Eswatini was able to push. The target was move all children from nevirapine to these others. So I'm just giving it as an example. When research came, show some results, Eswatini will be quick to adapt, use that evidence, and then be able to move, forward. So even all these transitions from single-dose nevirapine, I've seen all those transitions. When I started working from 2006, we're using single-dose nevirapine. You know, you are pregnant to take this pill when so helwa, you know, I remember we used to just say that, take it, and then whatever, we moved from single-dose nevirapine, we added AZT, we then moved on to ART, but only for women, we had CD4 less than 350, until now where we are saying, irregardless of your CD4 count, once you're HIV positive, you take ART. And in all those, you know, regimens that we're using, Eswatini, I can guarantee, was in the forefront. We were the lead, you know, when evidence comes and say this works better, boom, we move on. We move from single dose, let's add AZT, let's add ART, let's do this. So I think for me, those were the major factors: government, political commitment, PEPFAR funding, and also the swiftness in adapting new evidence and guidance that might come from the different bodies.
So let's talk about data, because PEPFAR stressed the importance of data-based decision-making, like you're attesting to the fact that there was this data coming through informing you that kids on NVP needed to be transitioned, and that was happening in a fast mode.
Yeah.
So what kind of data were you, we just talk about that data and reporting to PEPFAR that facilitated this swiftness, because you can only make the decisions based on the data.
Yeah, yeah. I think PEPFAR has grown over the years, and I'm fortunate to have been part of that growth. When we started, especially in the emergency phase that I talked about, yes, data was there, you know, data was being utilized, but it wasn't really as intense as later on, especially in the second phase, where which I talked about, where we were now scaling up, and that I think was the time of Ambassador Debbie Becks. So when we started, I remember partners would be asked to set your own targets, and then, you know, whether you achieve or not. I mean, it was just not a major issue. The focus was, please, let's do the work. Let's take the services, you know, I understand, because it was an emergency. But later on, I think around 2010 and so forth, data, use of data, even in that initial phase, it was being used, but it was just not intense. In the later, you know, mid-phase, 2020, and even up to now, data became so rigorously used. It was used to understand exactly where the needs are, where the gaps are. So even target setting was now done systematically. You were not just saying, I'll test so many people. It had to be informed by data. What is the gap? Where do we want to go? What is the need? You know, and all those kind of things. So data was now used to set the targets of where we are supposed to go, and even help in terms of allocation of resources. Instead of giving all the resources to one region, you know, maybe things are better there. Using data, you were now able to say this region is lagging behind, more resources, less resources to this one, so data, we could see now data being used rigorously, and also accountability. So as the partner, if you were given certain targets and you don't achieve them, I know it was contentious and controversial as well, but you know, it really encouraged people to start becoming more accountable and using data as a currency to identify exactly where the gaps were. So the data was coming from routine monitoring and evaluation that we're having. It was also coming from surveys that would be done here and there, and it was also coming from research. So we're having data from all angles. Your surveys, like your fears, will tell you in terms of the 95, 95, 95, this is the region that's lagging. This is the population that's lagging. I remember there were times where our data would show in Eswatini that men are lagging behind. Adolescent girls and young women are lagging behind. So it helped you focus in terms of where you needed to provide activities, where you needed to put more resources, what you needed to do, what you needed to change. I gave you an example of a research we did that showed this drug, you know, though it's working, but it's inferior to this other regimen. Children on this one are doing well. Why keep this one on? So all those data were now being used to inform, you know, decision making. It was coming from all aspects. Like I said, routine data that will collect for your monitoring and evaluation, surveys that will just do, you know, and also hardcore research that will actually do. And PEPFAR, I'm glad to say, played a key role in all those areas. Even when it comes to research, I think they've been groundbreaking research that we've done here in Eswatini as ECPAF that has informed guidelines. This issue, data that I'm talking about on nevirapine, helped even to change some of the guidelines for WHO coming from small country like Eswatini. Recently, we also did research around when a new drug was introduced, dolutegravir. You might remember, I'm not sure if you're aware, when it came in, there was a bit of an outcry because people thought it was associated with neural tube defects. So women will take it of childbearing age when they get pregnant. You know, their children would then suspected that they would then have this neural tube defects, you know, on them. And I think the early data came from Botswana. There was a study, they were collecting actually routine data. It was called Sepamo, you know, a study. So it showed that this drug was actually causing neural tube defects. So Eswatini took that up because we were going to introduce the drug. Like I said, the drug was very good. It had been shown that, you know, it's forgiving when it comes to resistance. If you miss a dose, unlike other drugs, this one wouldn't, you know, lead to resistance quickly. You take it once a day. So there were good things, but now there was this issue. The drug might be causing neural tube defects. Eswatini actually did a study, small as we are, big study. We did this surveillance in 5 maternities where we collected data on these women, you know, to see, is this drug really causing that issue? And we're able to provide evidence globally that has actually resulted, even as I speak, to the changing of how dolutegravir is categorized by the Food and Drug Association, FDA. And that's evidence coming from a small country like Eswatini. And this was done also by ECPAF, of course, working with the Ministry of Health, the Sexual Reproductive Health unit. So we've looked at the data and we've used that data and we've convinced ourselves. I remember even when we're introducing this drug, doctors somewhere like, you guys are killing babies, why are you doing this? Why? But now with the evidence, local, we've been able to show, no, that's not the case. And this information has been taken globally to the fact that FDA has even said, yes, the data from Eswatini has shown that this is this drug does not cause this. So that's some of the work that we've also done when it comes to research and actually using the data that comes from research to change not only locally but global, you know, our guidelines and guidance.
As we head towards wrapping up, I'd like to ask a general question about global aid and, you know, development assistance, that it could cause imbalances, you know, between the West and the African continent, and the fact that it reduces the state's autonomy and leadership to do certain things. So, I mean, after working in PEPFAR, I'm not sure if you have experience of other development assistance, but perhaps we can use PEPFAR because that's where the relevant conversation is all about. What has been your experience, your observations as far as this accession is concerned? What would be your impression of that?
Yeah, can you just repeat it? So the accession is, what was the...
Aid could contribute to imbalance between the West and the
oh, yes.
African continent.
Oh, yes. Yeah. So, I mean, this has been a very huge debate, ongoing debate. We've also sat down even within ECPAF and we've done a lot of debate. So we've even at one point in time had sessions that we're calling decolonizing aid or something like that. So this is
global or just Eswatini?
No, global as ECPAF, you know, global. Just looking at this and what exactly it has done. And honestly, there've been several schools of thought, and I'll also give maybe just my perspective. This is now me speaking as Caspian, personal, and it might not really represent the views of ECPAF as a whole. I think this has varied, honestly, in a number of ways. Number one, I've seen that our governments, I will just speak African governments in totality, tend to relax when we know that there is someone who is providing aid in a certain area. I know a number of African leaders have risen up and say, guys, we can do this on our own. We have the resources, we have the muscle, we have the capacity to actually, fund a number of these activities as well. Why are we not doing it? So there's been, and I would say to some extent for me it's true, there have been several governments where the resources are available, but because someone is there and is doing it, I just relax and either push the money to something else or, abuse the money. And we know that's something that that happens quite a number of times. So aid has also honestly resulted in some kind of passivity, like governments becoming very passive when it comes to rising up to the occasion and funding most of the work that they are currently doing. Secondly, yes, as a donor, you call the shots. Even within PEPFAR, as I said, I remember there were times where people would be up in arms, governments, even in my current role, where PEPFAR, as the donor, will say, you can't use my money to do A, B, C, D. And they have that right because I'm giving you the money and I'm saying this probably, I want you to focus on this area. And governments will say, no, my area of need is this one. I would want to use it for this area. So it becomes a bit of a clash. Like you are now controlling me. You are now telling me what to do. This one will say it's my funding. And so if you don't want to do what I'm telling you to do, then I'm not going to give you the money. So at the end of the day, to some extent, the aid became like a tool to then move people in a certain direction, which is not the direction I might have wanted to take. But again, this person who is being moved into that direction, the question is, could you also rise up and fund some of these things so that you don't rely just on your funding? If that becomes the case, then you are not always, a basket case where you are just always begging, and you can also, fund some of these activities. When I started my career, I've been told about this example of Ethiopia. I've heard it a number of times. Honestly, I can't verify whether it's correct or not, but I heard that Ethiopia, when PEPFAR started, again, focus was on HIV or on whatever. Ethiopia government said, no, when you bring your funding, your aid, please use it to strengthen our health systems, not just HIV. So there was a tug of war. We want, we will. But from what I heard, Ethiopia was able to, have their way and use that funds even for broader health system strengthening as well. So it worked for them, but for other government, it didn't. So if you ask me, I think it's on both sides. First of all, I agree. Aid can actually be used as a tool, to manipulate. If you don't, I won't. If you do this, I will. But on the other hand, aid has also caused some of these governments to be passive and not rise up to the occasion. I strongly believe most of our governments do have the capacity and the resources to do. And we've seen governments beginning to rise up. In Eswatini, drugs, ARVs are even bought, some of them by the government, which is good. In Zimbabwe, they introduced an AIDS levy, where they are getting money and they fund certain. So that's what we want to see. We have minerals, we have, lots of things that we are doing. Could we start rising and moving to where we are supposed to be? I think this is the phase where we are in right now of transition. Governments are beginning to see that, hey, PEPFAR might not be there forever. I know currently everyone agrees PEPFAR is needed. It's continuing, but we are seeing also funding being cut. I think recently there was voting that was being done about the budget, and I understand PEPFAR is one of those that is being protected as much as possible. The question is, until when will the funding continue to be at that level? So governments as well need to start rising up, as we are doing, taking over some of these services as much as possible. And I'm happy to say we are seeing our African governments, they are not where we would want them to be, but some are beginning to start taking up some of those activities and and are funding them, even given the recent termination of some of these funds, I think has become even a huge wake-up call, for our governments as well. So, yeah.
On a personal level, how has your involvement and working for PEPFAR programs impacted you, and also professionally?
I would say most of the work that I have done in my career has actually been in HIV. I would say 95% of my career has been HIV. I went into the HIV field early in my career. Like I said, of course, after internship, it was a bit broader, but I didn't do that for very long before I moved like 100% into HIV. And again, thanks to PEPFAR, I would say professionally, I've grown because of PEPFAR, even as an individual. Most of my funding of the work that I've done, even personally as well, I'll be very frank, my salary has been through PEPFAR, as well. So even professionally, right now, I'm known maybe in the field of HIV, mostly because of PEPFAR. Like I said, almost 85% to 90% of the work that we do at ECPAF is PEPFAR funded, and that's the organization that I've been with for the past 19 years. So I can say personally, PEPFAR has been like an anchor to me when it comes to my profession. I've grown in the profession that I'm in right now through, PEPFAR. So I'm hugely indebted. I don't want to lie to you, to PEPFAR. I would say my career maybe spans to 22, 23 years. 20 of those years have been in the HIV field, and 19 of those years have been under PEPFAR. So that's how PEPFAR has impacted me.
Thank you. So, do you think there's any misunderstood aspect of PEPFAR, or any voices that are not prevalent in telling the story about PEPFAR?
I actually don't think so. I think most of the voices, most of the people do understand. The level of understanding and the details might vary from one individual to another, but just as a basic, understanding that there's been this funding that has come from the American government that has helped in the fight against HIV and AIDS. I think it's almost like a globally understood, effect. The level, how deep someone might understand it might vary, So I think we've seen voices of communities, voices of political leaders, voices of people living with HIV, I think have been heard, across. I doubt, honestly, if I can say there is a specific group whose voice has not been ahead. It's just about the level of understanding of what PEPFAR has done, and also the level of the voice that we might need to hear. But I would say, yeah, most of the voices have been heard, and I've loved the way, I think this is one of the few conditions where the people who are directly affected, like people living with HIV, you have heard their voices being in the forefront. We have phrases like "nothing for us, without us" coming, from people living with the HIV. I think it's one of those diseases where people have really made their voices to be heard. Even in conferences, most of these diseases, when you go, the focus is on the academics, the voices of the researchers, voices of the programmers. But with HIV, with PEPFAR, even the people living with HIV, a huge part of these conferences, even in policies that are being done, guidelines that are being done, they've been a huge part of that as well. So I wouldn't say there's been a specific group that has not been heard, but it's just about the level of how loud the voice has been heard.
As I bring our interview to a close, globally, what do you think PEPFAR has contributed? I mean, in the larger scheme of global aid, do you think there's a particular shift that is unique to PEPFAR in the way that PEPFAR has done work and the impact that PEPFAR has had?
Yeah. I mean, I would say by and large, the successes we have seen in the field of HIV and AIDS, all these progresses we talk about in the 95, I'll boldly say the bulk of those achievements have been because of PEPFAR. So all the, increases we are seeing in people who know their status, people on treatment, people who are virally suppressed, I would boldly say the bulk of those achievements have been through PEPFAR. So yes, there's been a huge impact for PEPFAR. However, there's one thing I want to say. I mentioned it earlier on, and I wouldn't feel good if I don't emphasize on this.
Go ahead.
Despite the progress that we have made, my heart still bleeds for children. We come from an organization, I think we are one of the few organizations that has pediatric AIDS in their name, so we are so passionate about children. Our children are still lagging behind. Yes, progress been made, yes, but it's far, far behind that of adults. The recent UNAIDS Global AIDS report showed that only 55% of children who are living with HIV are on treatment. That's low. We've been in this pandemic for years now, and to still have children lagging behind like this, for me, is quite painful. It's quite sad. So work has really progressed well, and we really appreciate governments, we really appreciate PEPFAR, we really appreciate the healthcare workers, we really appreciate everyone who has done a remarkable job when it comes to this journey. But let's not forget that children are still lagging behind. Let's put triple efforts to make sure that children catch up. We always leave them behind. They shouldn't be an afterthought. How can we continue the way things are right now when we know still about 55% of our children, only 55% are on treatment? If you look at the number for adults, it's very high. So I would say, please, while we celebrate the progress that has been made, while we celebrate the big achievements that have been made, let's not forget that children are still lagging behind. Let's do all we can to make sure that children are also taken care of. I think I have to say that my heart is really sad when you look at the numbers. We're asking about data. This is what our data is showing, and it's very sad, honestly, especially in this time where we are in, where progress has been made, where all the tools that we need are there. We have the science, we have the treatment, we have the drugs, we have almost everything. Yes, back then we did not know what works, what. Now we have all the tools that we need. Why are our children still being left behind? I think that for me should be a sobering thought for all of us, and we should put all our efforts when it comes to that. Thank you.
Thank you so much, Dr. Caspian, for your time and your very valuable insight in this project. It's going to go a long way, and we are hopeful that this will culminate into something very impactful in the future when people listen to what you had to say in terms of your experience and PEPFAR in your professional life. So thank you so much. That brings us to the end of our interview.
Thank you, Tandega. It's been a pleasure. All the best. Yeah.